All right, we're diving straight into the high-stakes world of emergency medicine. We're going to look at two life-or-death cases where every single second and every single decision counts.
You know, the pressure in these situations is just immense. The margin for error is razor thin. When a patient is crashing, a doctor has to cut through this absolute storm of information to find the one action that's going to pull them back from the brink.
So I'm putting you in the hot seat. You're going to see what the doctor sees. You're going to know what they know. The question is, when you're faced with these two critical patients, can you make the life-saving call? Let's find out.
Okay, our first case. It all starts with a call to the emergency department. A patient is fading, and they're fading fast, and the reason why isn't immediately obvious at all.
So here's what we know. Our patient is a 76-year-old man, and he's feeling weak, nauseous, just really lethargic. His history of stage 4 chronic kidney disease is a major red flag, and his vitals are pretty concerning. Both his heart rate and his blood pressure are low. The body is clearly struggling with something. The team runs a blood panel, and one single number comes back that changes absolutely everything. It elevates this from just a concerning case to a potential catastrophe. His potassium level is 7.3. Now, just to put that into perspective, the normal range is somewhere between 3.5 and 5.0. This patient's level is sky high. It's a condition we call severe hyperkalemia, and at this level, potassium is literally a poison to the heart. And the ECG, the heart's electrical tracing, it confirms the danger. It's showing what are called peaked T waves, which is basically a visual SOS signal coming directly from the heart muscle. All that high potassium is disrupting the delicate electrical signals that make the heart beat correctly. So here's the crucial point. This patient is right on the verge of a fatal heart rhythm. What's your immediate move? Are you going to give him IV calcium gluconate, an infusion of sodium bicarbonate, rush him to emergency dialysis, or maybe administer insulin and dextrose? What is the one thing you must do right now?
Now, several of those things probably need to happen, but only one of them can be the absolute first priority.
The correct answer? You have to administer intravenous calcium gluconate. But why? Because the most immediate threat isn't the amount of potassium in the blood, it's the effect of that potassium on the heart. We have to protect the heart first.
I want you to think of calcium gluconate as a shield. It doesn't actually get rid of the enemy, that high potassium, but it forms this protective barrier around the heart cells. It stabilizes them and prevents that fatal arrhythmia. It buys you the critical time you need to actually go in and deal with the underlying problem.
And this lays out the full emergency plan perfectly. Step 1 is always protect the heart with calcium. Step 2 is to temporarily hide the potassium, forcing it out of the bloodstream and back into the body's cells. We do that with insulin and dextrose. And then finally, step 3 is to actually remove the potassium from the body, and that usually means dialysis.
See, those other options are crucial, but they take time to work. Insulin and dialysis, they will eventually lower the potassium level, but they don't act instantly. And in this situation, you don't have minutes, you have seconds. You must shield the heart before you do anything else.
Okay, patient 1 is stabilized, but in the ER, there is no time to rest. Just as you catch your breath, another critical call comes in. This is a completely different patient with a completely different emergency. This time, we've got a 39-year-old man, and he's in shock. He's dizzy, he has severe abdominal pain, his blood pressure is dangerously low, and his heart is just racing, trying to compensate. The key piece of his history here is nephrotic syndrome.
So what is nephrotic syndrome? Well, it's a kidney disorder where the body loses just huge amounts of protein in the urine. And a really dangerous side effect of losing these specific proteins is that the blood becomes thick, kind of sticky, and incredibly prone to forming dangerous blood clots.
So the team rushes him to a CT scanner, and there it is. The scan shows a filling defect, which is really just medical speak for a massive blood clot. And it's blocking a major vein that supplies blood to the intestines, the superior mesenteric vein. This is the smoking gun.
So the diagnosis is mesenteric vein thrombosis. The clock is ticking again, but for a totally different reason.
With the blood flow cut off by that clot, the patient's intestines are at immediate risk of dying, a condition called bowel infarction. So what's the priority now? Do you start antibiotics? Do you rush him to surgery? Or do you begin anticoagulation with a blood thinner like heparin?
And the answer is to immediately start a powerful blood thinner like heparin. The goal here is to stop that clot from getting any bigger and to help the body begin to dissolve it, restoring blood flow before the bowel dies.
Now, you might be asking, why not just rush to surgery? And this is a really key distinction. Surgery is reserved for complications, like if the bowel has already died or maybe even perforated. But right now, this patient's abdomen is tender, but there are no signs of that happening yet. The first-line treatment is medical. You have to treat the root cause, which is the clot itself.
So, 2 different patients, 2 different diseases, but the same life or death pressure. What's the common thread that connects these 2 very different decisions?
It all comes down to one fundamental principle. Treat first what kills first. In case 1, the immediate threat wasn't the high potassium. It was the fatal arrhythmia it was causing, so you shield the heart. In case 2, the threat wasn't the underlying kidney disease. It was the clot that was starving the gut of blood, so you stop the clot. This is the core logic of emergency medicine. Identify and neutralize the most immediate threat to life.
It really leaves us with a final thought. In the chaos of a medical crisis, when the body is sending out multiple SOS signals all at the same time, the true art of medicine lies in knowing which alarm you have to silence first.